Okay, so we're going to go ahead and start with Chapter 40. Now, before Chapter 40, there are 2 pages that have some information. The biggest thing that I got from those 2 pages was that cyclic AMP increases bronchodilation by relaxing bronchial muscles. And then you have your phosphodiesterase, which inhibits cyclic AMP. So if it does inhibit cyclic AMP, then you're going to have bronchoconstriction. Phosphodiesterase inhibitors actually inactivate phosphodiesterase, which allows cyclic AMP to continue its function, which is to cause bronchodilation. So that was the information that I got from those 2 pages prior to Chapter 40. And then continue on with Chapter 40, that's going to be drugs for upper respiratory disorders. Upper respiratory infections, you have 4 types of infections: the common cold, acute rhinitis, sinusitis, and acute pharyngitis. And the most common is the common cold. For the systems, you're going to have your nasal cavity, your nares, your pharynx, and larynx. Those are the components. You can review that on page 571 and give you a figure that you can look at. And there's 3 definitions that you want to kind of know. The first one is acute rhinitis, and it's acute inflammation of the mucosal membranes of the nose. Allergic rhinitis is hay fever caused by pollen or a foreign substance. And then cold system management includes antihistamines, which are your H1 blockers, decongestants, sympathetic amines, antitussives, and expectorants. The other definition is rhinorrhea, which is a watery nasal discharge. And then some of the things that could occur with any of these symptoms is you can have a bacterial infection, which is secondary to the cold. You can tell by the discharge of the secretion. Yellow or green would show signs of infection. We'll talk about a little bit more in detail later on. For antihistamines, as you can see, I got the number 1 next to it, so there'll be a couple other ones that we'll talk about. And antihistamines are H1 blockers, which are also called H1 antagonists. They're going to compete with histamine for receptor sites. When they do compete with receptor sites, there's going to be 2 types: the H1 receptors, which are extravascular smooth muscle, which will constrict, and then you have your H2 receptors, and they increase in gastric secretions. I'm sorry, I left out the E. I just not caught that. Sorry, I have a lot of typos on here. And then, another thing to know is your H1 antihistamines decrease nasopharyngeal secretions by blocking your H1 receptors. As we said, they're going to be competing with your histamine, so they're going to be blocking the H1 receptors for histamine to bind to. There are 2 types of antihistamines. You have your first generation antihistamines, which cause drowsiness, dry mouth, and other anticholinergic symptoms. Remember, anticholinergic should be the same as sympathetic or sympathomimetic. And then your second generation antihistamines have lower anticholinergic effects and lower incidence of drowsiness. Are you able to give me examples of second generation antihistamines? If you said cetirizine, Zyrtec, fexofenadine, Allegra, loratadine, Claritin, you were correct. Anticholinergic properties of most antihistamines cause dryness of the mouth and decreased secretions. One of these things is if they're having these symptoms, you can recommend the patient to have some gum or candy, even ice cubes, to have that extra humidity or just the moisture in their mouth. Diphenhydramine is the first generation antihistamine and should not be taken in conjunction with alcohol, narcotics, hypnotics, barbiturates because of CNS depression. So those are one of the things that if you look at the prototype drug sheet, that's going to have that on there. We talked about the second generation antihistamines. their names, but what they're going to do is they're going to have little to no effect on sedation. They're going to have fewer anticholinergic symptoms, and alizolastine, I'm not going to, acetylene, has 22-hour half-life. Next one, number 2, to talk about is nasal and systemic decongestions. These are your sympathomimetic amines. So they're going to stimulate the alpha adrenergic receptors, producing vasoconstriction of the capillaries in the nasal mucosa. There's going to be transudent fluid into the tissue space that results in swelling of nasal cavities. Infection, inflammatory, or allergy cause nasal congestion. So those are the 3 things that can cause it. And then for administrations, you're going to have nasal sprays, droplets, tablets, capsules, or liquid form. For the nasal sprays and droplets, make sure that you go back to page 136 and review the steps on how to administer nasal spray and droplets. There's going to be tilting, head tilting either forward or back. I believe nasal sprays are going to be forward looking at their feet, and when you spray the nasal spray in the associated nostril, that it's going to go towards that side of the eye. For droplets, there's going to be a head tilt back and then towards the closed nostril. But don't take that 100%. Just check on page 136. And then we talked about the other forms. Tolerance and nasal rebound congestion can occur with frequent use. So that's one of the things with your nasal and systemic decongestions. Be aware of nasal rebound congestion. I got this backwards. It's rebound nasal congestion. It's some say 3 days, some 3 to 5 or 5 to 7 days. So make sure you do the reading on that. So far from what we've established, it's on page 577, it's right under the second paragraph on side effects and adverse reaction. Use of nasal decongestion for as little as 3 days could result in rebound nasal congestion. Okay. Make sure you review nursing process for diphenhydramine on page 575. It'll be one of the drugs that you'll have to know. And then you also have acute coryza as profuse nasal discharge. Systemic decongestions include ephedrine, phenylphedrine, pseudoephedrine, and the ones in red are going to be your brand names: ephedrine, neosynphedrine, and Sudafed. These are often combined with antihistamine, analgesics, or antitussives in oral cold remedies. Systemic nasal equals longer acting than nasal decongestion. I'm sorry, I'm just trying to make sure I'm reading it correctly. So the difference between your nasal decongestion and your systemic nasal decongestion, systemic nasal decongestion are going to be systemic is going to be prolonged. Use of nasal decongestion for as little as 3 days could result in rebound nasal congestion. Alpha adrenergic drug is going to increase in blood pressure and blood glucose levels. So that's something that you want to be aware of. If a patient has hypothyroidism or has diabetes mellitus, you'd want to be aware of that. For your intranasal glucocorticoid steroids, they're going to be used for allergic rhinitis, and they have an anti-inflammatory action. Nasal dryness may occur with continuous use. Intranasal glucocorticoid undergo rapid deactivation after absorption with exception of dexamethasone. That's, I believe, all I have for that. And number 4, your antitussives are going to act on your cough control center in the medulla to suppress the cough reflex, taken for non-productive cough and minimize throat irritation. So if a patient does have chronic productive cough, you would not want to use this medication. Review prototype drug 40 TAC 2 on page 579 and nasal process. Number 5, expectorants. They're going to loosen bronchial secretion so they can be eliminated by cough. The most common is guaifenesin. And another thing is, since most of the times we're trying to not use any kind of pharmacological treatment, if you want to do non-pharmacological for this, you would just make sure that they are hydrating properly, so drinking enough fluids. Hydration is more important because it does promote the loosening of the mucus. 2 little things: review sinusitis and acute pharyngitis. All right. Special things to know about this. For your systemic decongestion, so you're going to have jittery, nervousness, and restless. We talked about if a patient is having cough episodes, you want to teach patients to perform 3 effective coughs before bedtime to promote uninterrupted sleep. And you always, for evaluation, you evaluate effectiveness of drug therapy. Determine that the patient is free from non-productive cough and has fluid intake and rest, has adequate fluid intake and rest, and is afebrile. Here's a caution. It says caution patient not used. Caution patient not to use more than 1 or 2 puffs 4 to 6 times a day for 5 to 7 days. Rebound congestion can occur with overuse. Okay, that's it for chapter 40.